superior vena cava and brachiocefalic veins for benign and malignant conditions. SVC obstruction most often occurs from malignancy, usually lung cancers. The disease is out of bounds, and for that reason, most patients are treated with endovascular therapies and stenting. Open surgical reconstruction more often is performed for stent failure and benign disease, and rarely, really rarely, for malignant conditions. Most of these patients can present with profound headache, upper extremity or facial swelling, blackout spells or syncope, and they have this unusual syndrome where they get short of breath when they sit forward. In advanced stages, you'll see dilated abdominal wall and chest wall veins as shown here. The diagnostic evaluation really involves CT or MR venography or standard venography, depending on the patient's circumstance. And that's really to help define patterns of drainage related to the obstruction as described by Stanford and Doty a number of years ago. And basically for types 1 and 2, flow is antegrade through the SVC or the azygos system. And in more advanced cases, in stage 3, the flow is retrograde through the azygos system. And then when both those systems are obstructed is when you get the dilatation of the abdominal and chest wall veins. If you look at our practice at the Mayo Clinic, which is a large tertiary referral center, you can see that we do very few open reconstructions over the past several decades. And in fact, stenting is becoming mainstay therapy in most cases. If we first start and take the patients that we've operated on for benign disease shown here, you can see that since the year 2000, fewer patients have been treated primarily by jugular bypass. Among the 70 patients so treated, 30 were male, 40 were female, and 42 of these were open bypasses, and the follow-up in this study was 4.1 years. If we examine primary causes, it was mediastinal fibrosis in about 44%, and venous thrombosis related to catheters or pacemaker wires in 54%. If we classify the level of the SV or type of SVC obstruction with the type of intervention, it's really those that had type 3 and 4 SVC obstruction that were underwent operation. Most of the time in our early experience, we use spiral saphenous vein grafts or prosthetic. In recent years, we've used femoral vein when the saphenous vein has been poor diameter, and we prefer that to the prosthetic. And this is just an example of some bypass grafts. On the left is shown a spiral vein graft taken from the left innominate vein to the SVC. Dr. Glavitsky did that operation. And on the right-hand side of the picture is left jugular bypass using femoral vein that Manju Kalra did. If we look at the 42 reconstructions, 22 were with spiral vein, 13 were with PTFE, and the remaining 7 were with femoral vein, and 1 patient had an allograft. 15 of the patients operated had failed stenting, and 2 of them had had prior reconstructions. There were no deaths. Major morbidity occurred in 8 patients. Prolonged ventilation requiring tracheostomy occurred in 3, DVT and bleeding in 2 each, and a pulmonary embolism in 1 patient. 6 grafts thrombosed early. 4 of these were prosthetic, and 2 of them were saphenous veins in which we placed a sidearm like a Y to the contralateral innominate vein, and all these but one of the sidearm grafts was successfully revised, and there were no complications with those reoperations. Over time, 5 patients died. None of these were procedurally related. 7 grafts went on to thrombose. 2 were spiral vein grafts. 1 was recanalized and stented, and the other one was revised with a femoral vein bypass. PTFE graft occluded, and this was also reconstructed with a spiral vein graft. In the remaining 4 patients, nothing was done because 2 of the 4 had multiple prior operations. If we look at secondary interventions in these patients, and this is all comers, including those treated with endovascular techniques, you can see that 10 to 20% of patients require a number of secondary interventions over the first 3 years, and once you get beyond that 3-year mark, both with stenting and bypass, things are better. If we look at secondary patency, vein clearly is better than prosthetic, and that was significantly different. If we look at clinical outcome with open surgery shown in the orange squares, most of these patients became asymptomatic after bypass, and only 3 had only mild improvement or no change in their clinical symptoms. If we look at the role for reconstruction for malignant disease, again, SVC obstruction is usually stented. However, the innominate and subclavian veins are more amenable to surgical reconstruction, and we've done this in patients with locally recurrent thyroid cancers, either papillary or medullary, some patients with angiosarcomas, and a few patients with malignant or benign nerve sheath tumors. Similar to the IVC position, we prefer a patch over segmental replacement. I'll just give you 3 examples of patients that I've operated on, and these are shown schematically. This patient had a right upper chest wall malignancy involving the subclavian vein. We were able to free the artery away from the vein, though you always have to be prepared in these situations to replace artery as well. And this patient was reconstructed with a spiral vein graft. This is a patient with metastatic papillary thyroid carcinoma in an irradiated field, involved the base of the neck. The jugular vein was nearly occluded, so it was resected. A portion of the subclavian and proximal left innominate veins required resection, and that venotomy was closed with a bovine pericardial patch. This is a patient that we recently did with an angiosarcoma in the neck, very thin skin and subcutaneous tissue. The tumor extended close to the esophagus and trachea. We were anticipating arterial reconstruction. In these situations, my preference is to use and harvest superficial femoral, which was done in this particular circumstance. The jugular vein was invaded by the tumor and it was resected, and we were prepared to patch the confluence of the subclavian and right innominate veins, but did not have to do so. And this patient had recurrent medullary thyroid cancer involving both the right subclavian artery and vein and a portion of the innominate vein in the upper superior vena cava. And this individual was reconstructed both with arterial and venous reconstructions, all done with prosthetic, as schematically shown here on the right-hand portion of the slide. So in summary, stenting is first-line therapy for patients with SVC obstruction of any cause, at least in our practice. Open surgical reconstruction is reserved for benign disease in patients who either are not suitable for or have failed endovascular treatment, and reconstruction with autologous vein is effective with long-term relief of symptoms. And most venous reconstructions for malignancies in this region are confined to the innominate subclavian veins. We rarely would reconstruct the SVC unless the disease is very localized. And most of these venous reconstructions are done for locally recurrent thyroid cancers, nerve sheath tumors, or angiosarcomas. Thank you very much for your attention.
Crônica das